So once the diagnosis is confirmed, then we can decide on the therapeutic intervention, what are the choices and what we do. So for unicentric Castleman disease, one area, and confirmed by CT scan it's only one area, that almost I would say curative treatment is surgery. You remove that one lymph node, which is Castleman, and very small chance patient would recur, especially if it is highline vascular, it's considered curative. We do follow these patients periodically, initially with CT scan once a year or so, and then less frequently, but their chances of recurrence are extremely small. When it's multicentric Castleman disease, we need to give systemic treatment. We cannot do surgery. And that brings about what are the options for treatment in this patient population. Till recently, we used to treat with drugs that are commonly used for lymphomas. Patients have been given chemotherapeutic agents, they've been given steroids, they've been given radiation sometimes to their local lymph node, etc. None of them have been very effective and or has longer lasting efficacy in this setting. Similar to lymphoma, patients have received Rituxan, which is an anti-CD20 antibody, very well-known antibody for treatment of lymphoma. And Rituxan has also been shown to decrease the lymph node size and improve the symptoms. However, it is not currently approved for this indication. However, based on the biology of the disease, that interleukin-6 is really connected closely with the disease itself, with the lymph node enlargement, with the symptomatology. Very recently, a new antibody called siltuximab was evaluated in Castleman disease, and based on this randomized study, very recently it has just been approved as a treatment of choice or approved treatment for treatment of Castleman's disease. So in this study, it was a really interesting study, a difficult study to be done in a rare disease. It was a randomized study where patients received standard supportive care versus or placebo with supportive care versus this antibody siltuximab with the supportive care. So it was really randomized placebo versus siltuximab study. Again, to do randomized study, putting more than 100 patients in a rare disease, it requires an effort. It was an international study, centers all across the world participated, many countries. And very importantly, for treatment of this disease, we confirmed that patients who got siltuximab had much higher response. There was a zero response in placebo, and there was close to 50% response in patients who got antibody. The symptoms improved, the laboratory findings improved, the lymph node decreased in size. And so from all different endpoints, it clearly showed that giving antibody provides benefit to the patient. And so as of now, I think the standard treatment for this patient is the only approved drug, which is siltuximab, that needs to be utilized for multiple purpose. It's a new drug, new study. We need to have longer follow-up. It seems that not only the initial treatment with antibody, but continuous use of antibody may be required, sort of a maintenance treatment. And those algorithms are being developed, but in other countries and even in United States, the antibody has been used to suggest that we should continue using it, and patients remain well, they remain functional. So important part of this disease is that the mortality is not high with this disease. It's not cancer. So patients do not die from this disease, except when they have aggressive disease, when they have HHV8 positivity, they have complications with HIV, etc. But regular patients with highline vascular or in many of the plasmacytic variant, their main problem is quality of life. So siltuximab really improves quality of life. If they feel fatigue, they have fevers, they have night sweat, they are bedridden, they can, once they are treated, can become normal. They can go back to their work and they can do what they can do. So I think it's the antibody improves their disease outcome, they improve their quality of life, and that's an important part of it. In some of the patients with localized disease, where I said surgery is the treatment, sometimes patients have huge lymph node. They have a big lymph node in the chest, very close to heart, very close to lung. May not be able to do clean surgery. So in some of those patients, I would give them treatment. In old days, we used to give rituximab. Now we would try siltuximab to try and shrink the lymph node. So even though there's a one-side lymph node, to make surgery possible, sometimes safe, we would want to shrink the lymph node and then do the surgery. So that's one of the things to keep in mind. One could have those options available. And I think this overall provides patients either some curative outcome or very good response. And then we have to maintain this response for a long period of time with continued use of the drug, or we can stop the drug and see how they do. Again, because it's a new drug, we need more experience over time to see what is the best algorithm. But currently, I think we need to continue the drug is our recommendation or our findings.